So we've got three speakers with us, and I had to move Greg Scott's picture over closer to Terry. So Terry, don't be concerned about that. But he's got a lot of words behind his name there, and a really long email address. And the order that we'll go in here, I think, is that Greg is going to do a quick overview, just verbally, of Protocol 36 for those who may not be aware of it. And then we've asked Terry Peterson from the Snohomish County 911 Center. Snohomish County was where the first COVID patient in North America was transported by ambulance. They were the subject of our first Paramedic Chiefs and IAED COVID-19 webinar and shared their experience. They have implemented 36. They were probably, in my way of thinking, one of the larger centers to implement 36 earlier, and to my knowledge are still in surveillance mode. We also have Tyrell Morris, the Executive Director of the Orleans Parish Communication District, that's New Orleans, who's joined us, who are in the thick of it. I think New Orleans and New York City are probably recognized at the moment to be with the most affected by COVID-19. They are using Protocol 36 and are beyond the surveillance level. And we wanted to really share their combination of experiences. Fellas, we'll have Greg Scott go first. Terry, since you had the first patient, we'll have you, if you don't mind, just give a quick rundown of your thought processes and implementation of 36 and any lessons learned. We'll turn it over to Director Morris to share his experience, and then I think we'll have questions and ability to just bounce back and forth in a conversational manner. If there's anything you want to show specifically, guys, I'm happy to give you control and talk you through sharing your desktop or slides or anything, but otherwise we'll just go with what you tell me to do. Greg, can you jump in and give us a little overview of Protocol 36, please?
Yeah, can you hear me okay?
Perfectly. There's a little echo, but go for it.
Okay. Sorry about that. So, yeah, just a brief overview of Protocol 36, and then we'll let the guys who actually use it in their centers give us their perspectives. So the starting point with Protocol 36 was the notion that during a pandemic, dispatch agencies need a relatively simple, robust triage tool when the system is becoming stressed. You know, it's beyond its normal capacity, if you will. And so a couple of things we thought about when we first looked at developing this tool was that it needed to be scalable. In other words, escalated at the local level based on the degree of system stress or system saturation. And so system saturation would not just be, high call volume. It could also be that all your hospitals are full and there's no beds to receive these patients, even if you have enough, ambulances to service all the calls. So that's part of it. And also the idea that we would expect to see during a pandemic, we would expect to see some workforce degradation. Paramedics and EMTs calling in sick, and therefore you're not able to staff all of your EMS units as per normal, even when the call load is escalating. So the idea was to develop a tool that, at the point of call intake and dispatch, that those patients that are most likely to have the disease, in this case COVID-19, and were symptomatic right now, to be able to put them through one dispatch protocol and triage them out in a robust way, again, to have that with the idea of having that sort of escalating, de-escalating kind of response levels for EMS. And this would allow for better allocation of EMS resources and system resources overall. So we developed something with the help of the CBRN group way back when we had the H1N1 pandemic back in 2009, 2010. Some of you may remember that. we developed this tool to start off with, and it was mainly, as you might expect, a true flu surveillance and triage tool. And there were some, when we looked at it recently, there were some still remnants of doing true flu surveillance versus COVID-19, which is not really a true flu. It's more of a respiratory coronavirus illness, as we know. So more recently, we have released, and that's been just in the last few weeks, we've released a new version of Protocol 36 that is COVID-19 specific. So you can actually choose the COVID-19 pathway, and it does streamline the questioning sequence a little bit more and make it more specific to COVID-19. And again, so the idea is that your dispatch determinants would be based on, sort of an escalating scale. The other thing is that we have streamlined the process by recommending that agencies where they would normally use 3 protocols, breathing problems, sick person, and chest pain, that they take all of those cases where the caller reports one of those things at 911, that's kind of their first primary chief complaint, but they take those 3 protocols and they instead of actually using them right out of the gate, they bypass those 3 and go straight to Protocol 36. So there is some dispatch training that takes place right up front where they have to say, they have to do something operationally different than what they've been used to in their standard protocol sequence. And I'll let the other guys talk about that a little bit. So that's kind of the idea behind it. And, in our analysis, the data that we have, those 3 protocols are 3 of the most frequently used protocols in the system. So they constitute about 1/3 of all your cases in most systems. It's going to vary a little bit from place to place. But so under normal operating circumstances, those 3 protocols would be about 33 to 34, 35% of your total call load, going all into one place and being triaged in one place, because that's where most of your COVID-19 symptomatic patients are going to show up in those 3 protocols. Doesn't mean we're going to catch them all there, but again, that's the most likely scenario. So that's kind of in a nutshell how it all works. And again, I'll feel free to answer questions, but I'll let the other guys do the rest of the talking. Thanks.
Great. And I think just to keep things moving, and because the conversation that the Snohomish County and New Orleans folks have might answer some of the questions that people may have, let's hold the questions until after the guest speakers chat. Terry, would you mind sharing your thought process experience? And I see that Kurt Mills is on as well, so who's the director of your center. So however you guys want to chime in, that's great. We appreciate your willingness to share.
Yeah, you bet. Terry Peterson here, and Kurt, please feel free to jump in if you'd like. So we implemented Protocol 36 at Snohomish County 911 back in March 7th. And we did that primarily because we wanted time to collect data to figure out how calls were going to be distributed between those different determinant codes. Even though we weren't seeing an increased call volume at the time, even though we weren't seeing an increased infection rate at the time, it was important for us to be able to start to analyze where are these calls going to land, so that when we do make decisions later on about, what types of units we're sending to what types of calls, we've got some, a base of information to go on. Some of the things that Greg just talked about, I'll touch on real briefly here. The training to implement Protocol 36 took us about 20 minutes per person. So it was a one-on-one training. The supervisor walked over and said, "Hey, I'm call taker. I want you to go through this training that we've put forth that talks about how Protocol 36 works within the MPDS system." It took about 20 minutes per person. It was pretty darn easy. We're seeing about an over 90% compliance rate related to calls that should be triaged on 36 are actually being triaged on 36. So that's a kind of a kudos to our staff that they're doing it right and getting those calls to Protocol 36, which is really important. Something else that we heard about a concern about whether or not we should move to Protocol 36 in surveillance mode was, additional call processing time. And the fact is that, if you're asking more symptomatic related questions for 911 calls, then yes, it is going to take a little bit longer to triage those calls. What we've seen on a 90th percentile basis is it's taken us about 60 seconds or so longer to triage those calls on Protocol 36. Now, once a call gets to Protocol 36, if they are having a chief complaint that's not related to COVID-19 symptoms, so what Greg was talking about a minute ago, sick person, chest pain, breathing problems, if those get routed back to that chief complaint, what we've seen is that on the 90th percentile, that's only adding about 15 seconds or so to those calls being triaged. So the point is that, for those really high acuity calls that aren't symptomatic, it's not taking a lot longer to triage those calls. So, after we've been on this for over a month, we're very happy that we have been, and it's been worthwhile just in terms of the data that we've been able to collect. A little bit on the PCR side, because we are able to, through some of the FirstWatch tools, we're able to kind of stitch together the big picture from, what we're seeing at the 911 center to what is happening in the patient care report side of the house. So the primary impressions that we're seeing for people that are screened through Protocol 36 by the providers are shortness of breath, fever, and generalized weakness. We did some analysis over the last week and got a list of all the confirmed patients within our county, and we overlaid those back to the determinant codes at the dispatch center, and we're finding the vast majority of people that are confirmed positive are being triaged on that Protocol 36. So that's another indicator that we are catching the people that we want, within that protocol. I think the last thing, and then I'll stop talking because I would really like to hear what Tyrell has to say with what's going on down in New Orleans. But, once we have this big data set of understanding how calls get triaged on Protocol 36, then we're able to start to figure out, okay, how else can we send aid resources to callers based upon, the triage level, if you will. And while we're still in surveillance mode, we are doing some trials for sending alternate response units or scout units over to low acuity calls. So specifically calls on like 36 alpha 3, which are, low acuity, flu symptoms only. We're sending scout units out and doing doorway triage and trying to, treat them a little bit differently that takes fewer resources and takes less PPE. So I'll go ahead and stop there, but I'm happy to answer any questions throughout the presentation.
Great. Director Morris?
Good afternoon, everyone. Thank you all for allowing us to be here. Can you hear me?
Yes, we can, and I'm going to give you permission to, I'll make you presenter so you can share your screen.
All right, can you all see?
Yes, sir.
All right, so you should see our website, correct?
Yes.
Okay, so here in New Orleans, as you can imagine, we have become a hotspot for COVID-19. The reason being, of course, we are a destination city, but the data is telling us that this virus is attacking the African American community very, very hard, and those populations that are disproportionately may not be the most healthy. And so we're in Louisiana alone, 70% of the cases in the city, or the deaths related to COVID-19, have been in our African American community. And so our leadership team here in the city of New Orleans has been leaning in to provide as many resources as possible to help protect everyone, from the patients to the first responders. OPCD is an independent agency that manages 911 and 311 calls. But we have the honor to have Dr. Emily Nichols as our medical director, who also is a medical director for New Orleans EMS. So we do enjoy that partnership, and we make decisions as a team. On our website, we have provided a timeline of what the agency has done all the way back from February 5th to respond to this particular pandemic. We have actually gone Protocol 36 and Level 1. So we are out of the surveillance mode, and we are actually in Level 1, where the responses have been altered. Our staffing has been increased to operate at level 2, and we've included that SOP here for any agency that needs to use it as a resource. But back in February 5th, in conversations with our leadership team here, our medical director, we did activate the EIDS surveillance tool just to kind of get an idea of what we were seeing or to kind of give us some heads up if we began to see a major increase in flu-like symptoms. Then we had Mardi Gras. We had a very successful Mardi Gras, and I will tell you from our leadership that's embedded with us throughout the Mardi Gras season, there were no red flags provided to us from the federal leadership that we needed to make a change, and so Mardi Gras continued as scheduled. We did have a tabletop simulation in March with our mayor and our leadership team to prepare, and then we went ahead and we had our first case. And so on March 9th, in consultation with our medical director, we did issue an emergency directive that activated Protocol 36, going from the surveillance tool to the true protocol, where we began asking the specific questions. And what happens is that line of questioning changes from asking questions about travel and contact to really more symptomatic surveillance. And so Protocol 36 gave us the ability. As our cases increased, we then provided some additional guidance on March 13th, where we actually moved to level 1 of the pandemic surveillance tool, Protocol 36. What that means is those individuals that have low acuity calls or 36 alpha 03, as Terry mentioned, those individuals do not get an ambulance right away. What happens is they go into a queue. There is a paramedic here in the 911 center with us. We initiate a video chat with the patient to get a try our best to get a more in-depth, a more informed decision of their symptoms. And the paramedic asks them additional questions, and based upon that assessment, the recommendation may be they self-quarantine at home following the CDC guidelines. Now, of course, if the patient insists on an ambulance or the paramedic decides, your symptoms are a little more severe than you are reporting, then that person at that time can then make the decision to send an ambulance. The city of New Orleans has also asked for just the average citizen to report to us if they are indeed having symptoms and self-quarantining. And so that self-quarantine registry, by using 311, a member of my team here in the PSAP, every 48 hours, we then place a phone call to those individuals, and we just check on them, ask them how their symptoms are doing. Are they getting worse? Are they improving? Just to monitor. And then, so if their conditions are worsening, we then take them through the triage tool and then make a decision at that point to send them an ambulance or not. And in some cases, in most cases, people are reporting that they have recovered and we can stop calling them. They say, hey, I'm good, stop bothering me. And so our goal is to prevent those individuals that are home alone from dying. And so the 48-hour check has proven to be very, very efficient in that regard. And we're continuing to monitor the situation, and our medical director and I speak on a daily basis, and then we make a decision if we evaluate the decision to increase the pandemic level to 2 or 3, but right now we're still operating at pandemic level 1. And with that, I'll take some questions.
So that's awesome. Thank you so much, Tyrell. And I'm going to, for all participants, I'm sending your link that you just shared, and then everyone who is on the webinar now, when we send out the recording link to this, we'll also send out that link as a separate link to go through it. One question I have for you is the information on there show what your plans are for response at each level beyond 1 and 0, or just does it have what you're doing with level 1?
No, it does. So in the Emergency Directive 2002, it does list, what the responses will be if the pandemic level increases. Now, I will tell you, every time we increase it, we reevaluate. And so, we may change some things, but the timeline will be updated. So anyone that wants up-to-date information, I would subscribe to if you go to our website, you can subscribe specifically for COVID-19 timeline updates if you're a PSAP director.
That's great. That's really nice that you're sharing that information. Before we open it up for questions to the group, I'll ask any of the panelists if they have any comments or questions for Director Morris.
This is Greg. I don't have anything right now.
Great. Okay, so what I'm going to do, let's give this a whirl, and if it's a ton of background noise, then I'll mute everyone, and then we can go back to trying to raise hands. Let's see, we do have a question already on the chat from Matthew Crossman. What platform are you using for video chat?
We're using Carbine as the platform because the reason we chose Carbine is because it has a couple other benefits as well. When we initiate the video chat, we also get location information, which in an emergency allows us to quickly move to get that patient the support. If we do a video chat, we find out they are indeed having a life-threatening emergency. We have the information we need to move quickly.
Great, and we'll make sure that is in the email information that we send out, because I think giving people a place to start with something that's working for you is exactly what this is all about. Okay, everybody, so I'm going to go ahead and unmute all. I apologize already if there are sirens and things in the background, and if it's overwhelming, I will mute everybody quickly and we'll start over. But here we go. We're going to unmute all. Mute. I appreciate it. But I'm going to mute you.
Sometimes it feels even harder, all these extra hours that aren't being reimbursed.
And Dr. Nichols, I muted your phone as well. So looks like that we're good. So let's see if anybody has any questions and wants to speak up. Go for it.
Hey, Todd, it's Darren. Can I actually start off with one for Tyrell?
Please.
So thanks, gentlemen, for joining us. I appreciate your time and bringing this conversation. One of the questions that I have that's not crystal clear to me, and I'm hoping that you might be able to help me understand, what triggers were you surveilling as you made the decision to move from level 0 surveillance into level 1 of the Protocol 36?
It really became about resource allocation. Also, when the CDC gave recommendations saying if you were having generic flu-like symptoms, their recommendation was to indeed do not go to the emergency room. It was for many reasons. One, to preserve the life-saving resources for those who really need it, but also to prevent yourself from further infecting other people or becoming infected when you go to the emergency room. And so we wanted to make sure that when people called 911, we gave them the best information available at the time about how to stay healthy during this pandemic. Also, you know, it's about resources. And at the time, New Orleans EMS, and Dr. Nichols has joined us, he's listening in, but they had a resource issue. And we're at one point, 60% of the personnel in the agency have been exposed. And so although every person that called 911 that needed an ambulance got one, it's important that we didn't know how quickly this was going to spread, or we didn't want to get into a position that we could not respond to those true life-threatening emergencies. And so the decision was made to be ahead of the game and proactive and raise the pandemic levels as to one, make sure we're giving the best possible advice to the citizens that call 911, but also preserve the resources for those who really need them.
Great, and let me just jump in really quickly. So some of you who had background noise, I muted you on WebEx. You're more than welcome when you're ready to ask a question to unmute yourself. The way you do that is in the participant window. If you find your name, over to the right of you, of your name will be a little red microphone with a line through it. If you click on that, that will unmute yourself. You can speak up and ask your question and then mute yourself when you're finished. I apologize for being rude enough to mute everybody, but we need to keep the background noise down. And Dr. Nichols, I did mute you, but I'm happy to unmute you for your input. It's obviously very important. Any other questions, thoughts? Darren, I thought that was great. I think that, you know, that's everybody's question. And, you know, Kurt, you made a comment on our CBRN committee. I'm not sure if you're still there, but about your perspective on Protocol 36 from a 911 Center Director. Do you mind sharing that again?
Well, yeah, I think Terry touched on it a little bit, but, you know, anytime you talk about changing your EMS response, it's a significant decision. And so, you know, my advice to anyone who is wondering when they should implement Protocol 36 in surveillance mode, I think the answer is immediately. When we started getting data in and we could see how calls were getting classified, we immediately knew impacts of the decisions that we may have to make. Unfortunately, we were still in surveillance mode. We haven't had to, but it gives us a great deal of confidence, and we can sit down with our medical director and with our fire agencies and show them, well, here's exactly the calls that we're getting, here's how they're getting categorized, here's what this means. And it's really become the centerpiece for the EMS response in our county.
Awesome. Thank you very much, Kurt. I think when I heard that earlier unequivocally, and you're right, Terry did say it in a different way, but to me, when you said it that clear, if you're wondering when, do it immediately, I think is really important to hear, because I hear a lot of agencies struggling because it is such a lift, and I think that knowledge that your recommendation, and you and Terry run a very large combined center, serve a lot of agencies, police, fire, EMS, is one of the more complex systems that I'm aware of, and for you to say go immediately says a lot to me. We do have a question from Brian Bernay. Was there any public relations outreach to explain to the public the temporary change in how EMS would responding? Tyrell, I bet that's for you.
Sure, yes, on many fronts. So the mayor and her administration have been leaning in, been very clear and transparent with the public on what to expect. So every press conference we had, I took an opportunity to remind people how to properly use 911, what it's for, and also just gave them a heads up, hey, when you call, you may get a video call from a paramedic. So they had an expectation of what was to come.
That's great. Are those announcements or resources? Do you happen to know if they're available? Examples of them are available anywhere on the government sites?
Yeah, if you follow the mayor on social media, on Facebook, they're all there. Okay,
great. I may get some tips from you on how for people to find that, so we can include them in the email, because I think that's super important that nobody has to reinvent the wheel, and obviously if it's working for you, let's use it.
Okay.
Hey, Todd, Terry here with a comment. Not specific about public outreach necessarily, but this is tangentially connected. We did get a list of all the adult family homes and nursing homes, skilled nursing facilities, and those sorts of things, which we all know are at high risk for spread of COVID-19. And we've reached out to them on multiple occasions, letting them know that, hey, if you call 911 and you have a patient that, you know, probably needs transport, then do everything you can to get that patient to the front door. Because the paramedics that are coming out there to take a look at that patient don't want to enter the facility. And it's really about reducing the spread of the virus and really about PPE conservation as well. And so, you know, we've done personal phone calls, we've emailed them. I think we have somewhere around 750 of those facilities in our county. And then we've also continually done pre-recorded messages to those folks. And I know that they've all been receiving that message. You know, that's sort of in lines with what we were just talking about with public relations.
Great, thank you. And Kurt also messaged that the Snohomish County fire agencies have used social media widely with pictures showing what they look like with fully donned PPE, so that people can know what to expect. I think both of those seem important. I remember when I was a medic 100 years ago, you know, if anything that looked unusual, people could be frightened, whether that be children or you know, people with dementia or other issues. And so as much as possible to prepare people for what will happen, I think is super smart. Other questions?
Todd, to that point, you know, PPE supplies have been, and we've all been struggling with supplies, and you know, when the fire guys are talking about maybe showing up to a house with swimming goggles and garbage bags on them, you know, we really recognize the importance to get something out into the community and say, don't be alarmed, because we don't look the same. It's still us, and we're still here to help.
Wow, great. That sounds really good. Well, I think we're doing really well on this. We have a couple more question minutes if we need to. We're going to skip the cross-country check-in. So if you were waiting for that to ask your question, please jump in now. Any other thoughts, suggestions, questions? I don't see any chat. I don't see any hands raised. So I think there are a ton of resources. I know Priority Dispatch is doing a lot of work on Facebook with some groups that are sharing quite a bit of information about Protocol 36, EIDS, and a new tool they're working to develop for online self-assessment using COVID. We're more than happy to help, really appreciate it. We'll post everything on the health intelligence pages. Everybody will get an email about this. I encourage you to sign up for the health intelligence page. Any questions? By the way, for those of you who don't have Protocol 36, Priority Dispatch and the International Academy have made it available as a PDF. It's at this link here. We will include that in the email that goes out. I'm not sure really how well it would work, but I commend the Academy for making it available publicly, not just for the Priority Dispatch users. And our next webinar will be same time next week. We schedule these right now for every Thursday from 10:30 a.m. to 11:30 a.m. Pacific time. You can get notified about them by signing up at firstwatch.net/HI. Unless we hear differently, I think Darren and I are leaning towards looking at how to help prepare staff for a line of duty death, and we will make that decision within the next day or two, I am sure. While we prepare for the last few minutes and signing off and questions, here's the EID at paramedicchiefs.ca for submitting anything that you think might be helpful for other people to see, and our emails for Kyle, Darren, and I are here. To our speakers, I cannot thank you enough for sharing your experience and you know, knowing what you folks have been through and your team have been through, and especially Tyrell, the posting that information on your site and giving people the ability to sign up for updates is just brilliant. So thank you for that. Any final thoughts? All right. Thanks, everybody. We're going to end this early. Speakers, if you can stay on for just a minute, we'd appreciate it. Thanks, everyone.